there's a big problem with the system. They're using expensive drugs that are toxic and have really little global impact.
Our neighbor's choice.
Well, I'm excited to have our guest today. He is Dr. Paul Marik. He's a world-renowned pioneer in critical care medicine. He's recognized as one of the most published in his field. He's held leadership roles in pulmonary and critical care medicine at Eastern Virginia Medical School. He's authored over 500 peer-reviewed journal articles and 4 books. He's a passionate advocate for evidence-based medicine and the co-founder and chief scientific officer for Frontline COVID Critical Care Alliance, FLCCC. But today he joins me because of what he's been working on for several years now, which is his investigation of the cancer disease, what's going on in that field of research. So thank you, sir, for coming on.
Sure, thanks for inviting me, David. As we'll get into, it's a very important topic.
Well, let's first start out with, kind of fleshing out anything more about your background, how you got to this topic of cancer.
Yes, so so I was a regular believing doctor until COVID came around, and so my world has been divided into pre and post COVID. So with COVID, I developed an interest in repurposed drugs because if you remember at the beginning, the NIH and the WHO said there's no treatment for COVID. You stay home and get blue, and then when you go to hospital, we'll give you remdesivir, which will kill you. And that was completely absurd because there's no disease that we know of that you're not going to try and treat. So we developed some treatment protocols for COVID and hospitalized patients with COVID, which largely involved the use of repurposed drugs. And so that's how I developed an interest in repurposed drugs. And just to be clear for your listeners, so a repurposed drug is approved by the FDA. It's just being used for an indication which is not licensed for by the FDA. And about 30 to 40% of drugs that physicians prescribe are used off-label, and it's perfectly legitimate, it's perfectly legal, you don't need patient consent. But suddenly with COVID and ivermectin and hydroxychloroquine, everything changed. Suddenly you weren't allowed to prescribe ivermectin, which billions of doses have been prescribed. It's one of the safest drugs on the planet. And if you remember, the FDA's slogan or logo was, "You're not a horse, you're not a cow, don't do it." And that became the mantra. And, to this day, people think that it's a horse deworming medicine, whereas it's actually approved for use in humans. Mm-hmm. So that's how I started my interest in repurposed drugs, because there's a lot of misinformation. Obviously, Big Pharma does not like repurposed drugs because they don't make any money. And then I was listening to a recording of a person who had had cancer and had treated her cancer successfully with repurposed drugs. And then I started thinking about it and started researching. And basically, based on that interview, I kind of developed an interest in this field. So, people think there's no science. I've read over 3,000 peer-reviewed papers to do with repurposed drugs in cancer. So there's an enormous amount of literature out there. It's just oncologists don't want to talk about it because they're scared. We know that traditional oncology is largely a failure. Probably the best example I can give you is there were 2 studies done in which they did a survey of oncologists, And they asked them, if you had cancer, would you want chemotherapy? A reasonable question to ask them. 75% said no. So they said no because firstly, it's toxic, and secondly, it's largely ineffective. So the drugs that oncologists are giving to patients and making thousands, if not millions of dollars, they wouldn't use on themselves. And I think that tells you the state of the art of oncology. There are a few tumors, you know, uh, testicular tumor, choriocarcinoma, lymphoma, in which chronic myeloid leukemia, in which traditional chemotherapy has a role. So I'm not saying it doesn't have a role, but I think in many of the more common solid tumors, breast, prostate, colorectal, chemotherapy has a very limited role in improving patient outcome. The data shows, aggregate data shows that extends life by 2 to 3 months. And we're talking about drugs in excess of $100,000. So there's a big problem with the system. They're using expensive drugs that are toxic and have really little global impact.
And of course, I've long criticized the FDA system because the way it works, when you have a government monopoly that decrees what is medicine or not, it's easy to game that system to the point where now it costs practically $1 billion or so to get approved by the FDA, which precludes all generic drugs or natural substances that cannot be patented from being properly researched to the same degree that new drugs that can be patented can get. So that totally violates the foundation of the scientific method from the get-go. It just biases it completely.
Absolutely. I agree with you 100%. I mean, the system is flawed. What they want is randomized double-blind studies. These they consider the gold standard, and there's nothing gold about that standard. And obviously, only big pharma can afford it. So the system is completely gamed. And we know that observational studies, if you look and compare them to randomized controlled studies, often have very similar results. So, this obsession with randomized double-blind studies has to stop. You're going to look at the totality of the evidence, and there's very good evidence for repurposed drugs for very many different indications, but the current system is such that it becomes too expensive to, get the labeling changed. So the system has to change. It's corrupt because it favors big pharma and big pharma's agenda, which has nothing to do with healthcare.
And of course, I'm having you on because this has been a topic of great interest to me for some time. And I have endeavored to put together what I call the Manhattan Project for Cancer, which is basically just a network of folks that I know are passionate about metabolic paradigm, solutions for this disease. And I take a very kitchen sink approach at this point in my investigation. I come at it as a journalist, as someone who's investigating the facts wherever they go, and I'm looking to see, what works the best, what's the cheapest, simplest, most replicable, most easily repeatable, and getting the same results across the widest spectrum of tumors, and then trying to whittle it down and find out over and over again combinations that are the most effective. And so, to that extent, I'm developing a lab to do these types of cell culture experiments using what I call a tournament of molecules. That is everything. If there's ever been something that includes things that most people consider to be quack stuff or whatever, throw it and let's see what happens. Throw it into the mix against these various common cell cultures for various the most common cancers, and let's see what effect it has, and put it against traditional, more widely touted anti-cancer. And this is something that, again, if you get into the alternative world, we know there are things that don't work. We know that there are, and that's partly, again, because the center of gravity has been so warped towards finding new drugs that there's this this kind of hinterland world out there where it's hard to know what's the good and what's bad, and it becomes folk medicine to some people, and they get afraid and they try something and then they get scared by their doctor, and it's just a mess. They say, well, it's so recently. I think your work has really caught people's attention online because of two, drugs that have been again touted as kind of underdog drugs for this last disease we just dealt with, actually having some results with this bigger disease. This has this huge cash cow industry behind it, and that's ivermectin, and then this fenbendazole. And I know there's a variation of it that's used, and we can get into that. But these two drugs, Mel Gibson popularly, he put it on the map. Tens of millions of people paid attention to him and Joe Rogan talking about these two drugs in the use of cancer treatment, and it spread like wildfire. So could you speak to those, or maybe you need to back up and go somewhere else first? You just go where you need.
So um, there's a group that's looked at repurposed drugs for cancer that have in vitro or in test tube activity. And there are probably about 250 different drugs. So there are many drugs that we use. And what we've done is we've tried to rank them according to the biological pathways, their consistency in vitro, and then some clinical data. So we rank them. And in fact, two of the most highly ranked drugs is ivermectin and mebendazole. And they've been, people think this just suck out of thin air. There are many, many, many peer-reviewed papers that look at the biological pathways of ivermectin and mebendazole in cancer. And so unlike traditional chemotherapy, which usually, the goal is to act, it's a completely wrong approach, act on rapidly dividing cells to alter the DNA. These drugs act at multiple sites and metabolic pathways, and these have been very well described. So they affect cell killing, cell cycle. They affect glucose metabolism and metabolism. They affect the microenvironment. They affect angiogenesis. So they affect multiple different parts of the pathway. And one of them is ivermectin. There's not a lot of clinical data because it gets censored, but there's a lot of in vitro data. There's a lot of mechanistic data. And so in dealing with patients who actually have disease and take ivermectin, we've seen some remarkable results. I can just give you an example, because sometimes patients feel compelled to call me and to thank me. Not that I mean, because I don't charge for anything. And so it is kind of validation. So I had two patients call me this week, one with a brain tumor and astrocytoma. They tried multiple surgeries and failed. So he had tried our approach, and his most recent scan was clear, completely clear. And he was really happy. And the second one was a patient with multiple myeloma, which is a blood disease, and he had failed chemotherapy. He had then a friend of his gave him my book, and he read the book, and he did some of the stuff, and he went back to his oncologist who did a bone marrow, and the bone marrow was normal.
Wow.
So we know it does work. We wished it would work on all patients, but we try the best we can. But we know that you got into it somewhat. The current paradigm of cancer is that this is a mutation. This is a chromatin or chromosomal disease caused by mutations. And we know that's how therapy is directed against DNA and chromosomes. We know that theory is largely incorrect. There are a few genes that are involved in increasing your risk, but it's not just the DNA, it's a metabolic disease. Thomas Seyfried has pioneered this on the work of Warburg, And there's absolutely no question of doubt that cancer is a metabolic disease with metabolic reprogramming of the cell. And so, what, as I'm sure you understand, having read this, so what most of the drugs and pharmaceuticals and nutraceuticals we use, they target various metabolic pathways to starve the cell of energy. So basically, once the cell is starved of ATP and energy, it dies. And then it obviously targets the microenvironment. So unfortunately, most oncologists don't want to believe this, that the theory on which they base their treatment is likely false. The National Cancer Institute still believes this nonsense. And I think that there's a very large body of evidence showing that this is a metabolic disease.
Yeah, and so I've had Dr. Thomas Seyfried on my show many times since about 2017, I think, is our first show together, and I've seen him blow up again on the internet very widely, and it's exciting to see, because I remember those days when I was like one of the few guys talking to him in a broadcast radio format that I was doing the show, and now so many people are taking a look. So do you use his therapeutic ketosis approach into your protocol?
Yeah, so it's written in a book, and
And what's the name of the book that you're referencing
it's
for folks?
called. So it's in the second edition. It's called Cancer Care. You can get it on Amazon. It's like $12, I think. It's not expensive, and I'm working on an update because the field changes every day. I learn something new every single day. For example, today I learned about vitamin D. So we use vitamin D for the treatment of cancer, and you need high levels, close to 100. And so we were suggesting that to prevent cancer, you use a similar approach. But I discovered today, going deeper into the literature, that very high levels can actually cause cancer. So to prevent cancer, you actually want to target a slightly lower level. So, things are changing all the time, and, we make mistakes, but we correct them. That's science. Science is not finite, it's not solved, it's ongoing, and it's self-correcting. And so you have to believe in science because that's what drives this.
Yeah. Another thing that I've looked at over the years is the antibiotics. How do antibiotics in your investigation work on cancer? Because this is something that ever since I remember having my show, my co-host is a NASA physicist named Dr. Wei-Ping Yu, and I always asked. He has a theory of everything that I find compelling, and I've always asked him, if your theory is correct about physics, what would you use for treating cancer and dealing with cancer stem cells? And he said, I would use, this is just him from his physics principles. He said, I would use azithromycin, like this macrolide antibiotic. And I investigated it, and I found the work of a doctor and professor over at Salford University at the time, Dr. Michael Lasanti, was using doxycycline for cancer stem cells. Is that something that you got into as well, or how did you find the
Yeah,
antibiotic piece?
so you're right. There's a lot of data on doxycycline. There's a little bit on azithromycin. So doxycycline is part of our protocol, and in fact, we've revised it. What we discovered is that the traditional way of giving repurposed drugs is to give them continuously every day. And we kind of reckoned that what that does is it leads to cancer resistance. So patients initially respond, then, 1 to 2 years later, the cancer, gets uncontrolled. And so what happens is if you have constant pressure on these cells, you're selecting out, via evolutionary biology, you're selecting out resistant cells. So the way you prevent this is by rotating drugs in different combinations. So what we do is, in our most recent update, which will be on our website soon, is we rotate doxycycline and mebendazole as a fundamental concept. And so doxycycline is not really working as an antibiotic, killing bacteria. It has different biological pathways. What it actually does is it binds to mitochondrial RNA and actually interferes with mitochondrial energy production and oxidative phosphorylation. It also interferes with the tumor microenvironment and the matrix of the tumor. So it acts via multiple pathways, as most of these drugs do. As I said, they don't act via one pathway, they have multiple different actions. Doxycycline is somewhat unique because it does bind to, so obviously there's DNA and RNA in a mitochondrion, and it binds to the mitochondrial RNA.
So what is the kind of taxonomy of defense here? And when you work with the protocol, I know you have your book where you can go into detail, but is there a baseline foundation that does 60% of the work, say? Like, is it the
Yeah,
ketogenic
yeah.
diet that does 60% of the
Uh,
work, or the drugs do 30, or is it opposite? The drugs are doing 70%, or how does that work?
Yeah, now that's a good question, and it's difficult to quantitate because diet and ketogenic diet is completely central to what we do. And so most oncologists, if you're a patient, because we hear this all the time, they ask their oncologist, what can I eat? And the oncologist says, it doesn't matter what you eat, you can eat ice cream or chocolate or cake or whatever, makes no difference. And we know from their published literature, their own published literature, that if you have, for example, colorectal cancer resected and you have high blood glucose and high insulin, it significantly increases the risk of recurrence. So diet is a fundamental starting point. So, it's the first thing you have to do is change your diet. You have to have a diet with low processed foods, low glucose, trying to keep your glucose as low as you want, because by the Warburg effect, tumors are highly dependent on glucose. So by limiting glucose intake, you kind of starving them. On the other hand, ketones, which the body makes in response to low glucose, cancer cells can't use ketones, whereas normal cells can. And at the same time, ketones have a lot of anti-cancer activity. So we feel that the first step along this journey, and it is a journey, is changing the diet. And at the beginning, it may be hard for patients, but they have to at least start somewhere, ideally to reach a ketogenic diet, but certainly to reduce the intake of processed carbohydrates.
Mm.
And there are patients who cured just by diet alone. Um, there is a book that I read recently by Guy Tannenbaum, who had metastatic prostate cancer. He didn't like what the oncologists were telling him. So just by changing his diet and going on fasts, he has cured himself of metastatic prostate cancer. So it's not something we would recommend to do alone, but I think together with the nutraceuticals and drugs that we suggest, they work together in synergy. And, if it's 50-50, I don't know. It would be difficult to do such an experiment. It would be somewhat unethical because, you wouldn't want to give a patient inferior therapy. So to have a placebo arm where that you didn't alter diet, I think would would not be ethical. So it's a combination of diet change, lifestyle change, as well as repurposed drugs.
Now you talk about vitamins. What vitamins do you find effective in your research for folks with cancer? Do you I've heard so many different competing. You mentioned vitamin D earlier.
Yeah,
Uh,
so yes, it's a really good question. So vitamin D is probably the most important, and there are hundreds of papers demonstrating this. There's no question that low vitamin D levels increase your risk of cancer. And most patients who present with cancer have a vitamin D level less than 20. It's kind of a universal finding. And what's interesting, as you go further from the equator, either north or south, you obviously get less ultraviolet radiation and lower vitamin D levels, your risk of cancer goes up. And there's no question that if you supplement with vitamin D, you reduce the risk of cancer. So vitamin D is really important. That's about it. Vitamin C, high dose intravenously, together with chemotherapy, has been shown to have a role. So recently there was a study in patients with pancreatic cancer who were getting regular therapy, but once they added intravenous vitamin C, it significantly improved the outcome. But the caveat about that is it doesn't work alone. It causes oxidative injury, which potentiates the activity of chemotherapy. So those are the two vitamins we suggest to use. Unfortunately, vitamin E, vitamin A actually increase your risk of cancer. And there's some evidence that the B vitamins may do the same because they're required for cancer cell growth. And folate is a good example because one of the earliest anti-cancer drugs was antifolates. These are the earliest chemotherapy which decrease folate level and cause cancer cell death. So it does follow from that giving lots of folate will cause the cancer to grow. And that's exactly what it does. And high levels of B12 do the same thing. So one has to be careful about using vitamins together with our protocol or together with chemotherapy. Mm-hmm. So I should tell you what I think is optimal. And so in reading about all of this, I think that standard oncology has a role. I think what we do has a role. Probably what's best is an integrative approach. And there's something called metronomic chemotherapy. So what metronomic chemotherapy is usually one chemotherapy drug used in a lower dose, which doesn't have all the toxic side effects of chemotherapy. And the drug that's used most frequently is cyclophosphamide. It's 25 or 50 milligrams a day. The patient takes it orally. Why this is so important is cancer is a global disease. It affects first world and third world countries. Third world countries can't afford the $100,000 that Big Pharma is charging. Cyclophosphamide is a repurposed drug which you can get a month's supply for maybe $40. So what you do is you combine cyclophosphamide together with our metabolic therapy of reprobate drugs and diet. And I think that's the optimal approach. So you're combining some chemo, diet, and repurposed drugs. I think that's probably the best combination. But it obviously needs to be tested. This is an evolving field. As you know, most of the studies are looking at new pharmacological pharmaceutical drugs rather than repurposed drugs or cheap alternatives. But obviously, we make up only a small fragment of the world's population. And so, we have a responsibility to look at treatment options that are applicable across the world.
You haven't mentioned much about surgery and radiation. How do you see them having a big role in cancer treatment going into the future?
So it's a good question. I think if it's a surgically removable tumor, I think so. It has a role. So for example, lumpectomy, you want to debulk the tumor. So in terms of killing the cancer cells and getting rid of the tumor bulk, often surgery has a role. And I think probably the best example is a lumpectomy, a non-radical mastectomy, which is non-deforming, removes the bulk of the tumor. And then you supplement this with, maybe cyclophosphamide and repurposed drugs and diet. So I think surgery does have a role. The role of radiotherapy, I'm not sure. I'm not convinced. And one of the interesting things is chemotherapy and radiotherapy actually activate cancer stem cells. It's an interesting thing that most oncologists won't tell you. And it's the cancer stem cell which gives rise to late recurrence. So chemotherapy and radiotherapy are of two forms of therapy which actually increase the risk of late recurrence. And that's why we say if you're getting those therapy, you need at least to use some of our repurposed drugs which target the stem cell. And as it happens, ivermectin and mebendazole target the stem cell.
Well, it's like my friend Dr. Lasanti says that he says that the standard protocol does not really address cancer stem cells at all. It typically just focuses on the tumor and shrinking it and attacking it.
Absolutely, you're absolutely correct, and that's a major limitation of current therapy because it's not dealing with the whole problem. It just deals with the actively dividing cells. It completely ignores the stem cells. In fact, as I said, some of the therapies actually activate the stem cells. So some chemotherapy drugs have been shown to activate stem cells, as is radiotherapy. So it becomes absolutely critical, whatever treatment path you decide, you do need to take some agents or drugs which target the cancer stem cell. And the cancer stem cell is like the roots. It's what gives rise to the tumor. And it's obvious if you don't get rid of the roots, it's just going to grow back again.
The roots, the stem cells, what is in your protocol that targets them?
Yeah, so many of the drugs, metformin, ivermectin, mebendazole, doxycycline, curcumin, all target the stem cell.
And what does it do? Does it try to eliminate them or,
Yeah, so it works on metabolic pathways which destroy the stem cell.
Mhm. uh, when you when I've investigated this subject, just in a broad sense, I've heard some people say that there's a paradigm, and that paradigm that they talk about is that cancer people focus on killing and attacking the tumor when really it's downstream side effect from a super stressed body that has become metabolically blocked and deficient and malfunctioning. And so, in their paradigm, they're not interested in attacking the tumor and breaking it up. They don't accept the conventional therapy approach to that end, and they do not accept alternative approaches to that end. They instead want to metabolically heal the patient so that basically the cancer cells are able to be healed and turned back into normal functioning cells that are optimally able to handle glucose like a child normally would be able to, where they're not having dysfunction and the excess buildup of lactic acid and all these other symptoms of a cancer friendly environment that happens seemingly with age and other stressors to the body. Have you looked into that approach at all?
So
It
I
sounds like your
yeah,
approach is more about killing the cancer stems, the
yeah. So
cancer.
I'm not sure if you could convert it is possible, I suppose, by altering the metabolic pathways, a cancer cell to a normal cell. But what you may also be referring to is the immune system. And so traditional chemotherapy, if you think about it, knocks out the immune system. It knocks out the marrow. It knocks out the T cells and the B cells. And these are the cells which kill cancer cells. So the immune system, we have a very good system of immune surveillance. And it's only once immune surveillance fails that cancer actually develops. So what you want to really do is while you're killing the cell, you want to activate the immune system so that the B cells and T cells uh, kill the cancer cells and that the suppressive cells, so there are cells called Tregs and myeloid dependent suppressor cells, you knock them out. So it's really a form of immune therapy. And many of the drugs that we do, for example, ivermectin, converts a cold tumor to a hot tumor because it becomes infiltrated by inflammatory cells which destroy the cancer. So it's our approach, I think, is all encompassing. It deals with angiogenesis, it deals with immunity, it deals with stem cells, it deals with rapidly dividing cells. And improving cell-mediated immunity, I think, is really important because that's how cancers develop, because they escape the immune system. Obviously, people have heard of this physician in California who has this drug which stimulates the T killer cell.
Yeah, Dr. Patrick Sun-Shing, right? Yeah.
Yes, yes. So it's a very expensive drug. Unfortunately, that's what he doesn't tell you. It's like $30,000. And so his approach is correct, is that what you want to do is, and he said this, giving chemo and destroying the immune system is nuts. What you want to do is activate the immune system. So his therapy activates T killer cells, which I think is correct. The problem is it has a limited target and it's very expensive. And so what we really need is, just because the data shows that in the US, 60% of patients with cancer develop financial problems or go insolvent because of the price of drugs. So, we have to think of the reality of how much these drugs cost and how much, what we can do for these patients.
Do you have a working theory as to why humans develop cancer? Everybody tends to say, oh, it's processed foods, it's environments, it's stress, it's this, that, plastics, that they just throw all these kitchen sink answers. And that's fine if that's where we're at. But have you been able to look deeper and say mechanistically why cancers form in the first place in the human body?
So it's a good question. Albert St. Kent, or whatever his name is, basically calls this the cancer paradox. St. Kent, he described the Krebs cycle. Basically, multiple different inciting events can give rise to cancer. And I think the bottom line is the way that happens is that the unifying theory is it damages mitochondria. So I think there are multiple pathways. These can be oncogenic viruses. This can be toxins. This can be bad diet and hyperglycemia. All damage the mitochondria. And so that then gives rise to, the metabolic theory. And if you look at almost all cancers, they have very dysfunctional mitochondria. And then that's the initiating event. So it seems to be, as far as we know, that multiple different inciting events, because we do know, the different paths to get cancer. But the unifying concept, Zent Gorgi was his name, is through mitochondrial damage.
Yeah. So what do you think is damaging our mitochondria to exist in this environment?
Yeah, so, I think there are lots of things. It's diet, it's radiation, it's pesticides, it's oncogenic viruses. So I think there are multiple, for whatever reason, multiple avenues which lead to mitochondrial damage.
Is there anything in particular in the diet that you think is most causing of this? Is it too much sugar? Is it grains? Is it
Yeah,
vegetable
it's too much
oils?
sugar.
Yeah.
There's no question of doubt. And in fact, studies have shown that, I think in the women's study, that those women who had the highest level of highly processed food had the highest risk of cancer. So there's no question that high processed food with high glucose gives rise to the metabolic syndrome and high insulin levels. And it's the high glucose and insulin level which drives the carcinogenic process. Now, how that targets the mitochondria, and you're going to have to speak to Dr. Ziefried or a molecular biologist, because it's a very complicated topic. But there is no question of doubt that highly processed food, high sugary beverages, sugary beverages, fruit juices, all these food types that have very high blood, result in high blood glucose and high insulin level, it leads to cancer.
What are you involved with any studies right now, or any particular cases that we can look to, or maybe it's been published already or will be published?
So we did publish a review paper on turbo cancers. So these are cancers that arise after the vaccination, the COVID vaccine. So people think that this is a anti-vax conspiracy theory. There's absolutely no question of doubt that this is real and that vaccination increases the risk, COVID vaccination increases the risk of cancer. There's some very good studies. One in South Korea was a population study of 8 million people, and they showed within 1 year there was a significant increase in cancer related to the vaccine. So it's not a it's a reality, which is very scary considering the number of people that have been vaccinated. So we wrote a review on turbo cancers. The other paper we wrote, which is kind of interesting, is what we call the Roots protocol. So, 1 in 2 people are going to get cancer. In your audience, half of the people listening to this podcast or whatever are going to get cancer. So what we really want to do is reduce the burden of cancer. And so we've come up with what we call the Root protocol. So it's a combination of nutraceuticals and exercise and sleep, which reduce your risk. And so we published a paper on the Roots protocol. And basically, the higher your risk, the more intense protocol you need. So, for example, if a man has a first-degree relative who's had prostate cancer, particularly below the age of 50, he has a very high risk. Now, if there's more than one first-degree relative, it puts him in an even higher risk. And if he's of African-American descent, it puts him in an even higher risk. So you can, for prostate cancer particularly, you can risk stratify men according to their risk, and you can actually then, adapt one of our protocols, and it's not cumbersome. We're talking about, vitamin D, curcumin, omega-3 fatty acids plus exercise, simple interventions to hopefully reduce the risk of getting prostate cancer.
What is your view on the role that maybe the NIH under Dr. Jay Bhattacharya might be able to play to help elevate some of this? We've seen folks like Robert Kennedy, have hit or miss opportunities to advance a different paradigm of medicine. Seems like they take one step forward and two steps back when you read the news, but we know how hard it is to fight against that machine that is up there that makes such a killing off of our medical system. Pardon the pun. What is your view on support that may come or may not come from agencies
Yeah,
like that?
yeah, the NIH, I think, has a critical role to play. And, it's still early it's a year down the road. So maybe, with time, we can see even more dramatic changes. But I think the NIH needs to refocus the research they're doing, and it should look at chronic diseases. It should focus, not on high expense, pharmaceutical products. It needs, because most Americans can't afford it, and people across the world can't afford it. So they have to be realistic and pragmatic and look at, what interventions can we do that are cost effective. They have to look at cost effectiveness. And I think they need to focus on repurposed drugs. Such an enormous opportunity for them.
Mhm.
And so there are many studies they could do with repurposed drugs, and they're not expensive, but I think that's what he needs to do.
Have you been able to talk to his people or anybody? I'm sure they're aware of what you guys are doing. You guys have always had
Yeah,
such an outsized role in public conversation, really. You punch above your weight in terms of your, I know you're not loaded with millions of dollars backing up what you're doing.
yeah, we're trying, but the pharmaceutical medical industrial complex is a juggernaut. They have unbelievable and unlimited resources So we're fighting it's a David and Goliath kind of situation. We up against enormous pressure. And most congressmen, 95% get financial support, doesn't matter which party, from Big Pharma. So, and it's really interesting how they criticize Kennedy, whereas when they themselves are being bribed by Big Pharma and their lobbyists. So unfortunately, the system is rigged.
Yeah. And it's, I wonder what, what power someone like, because, these are figures that have been on my show. People like Jim O'Neill, who's I think he's the assistant HHS director under Bobby Kennedy, and people like Jay Bhattacharya. These people are fans of this very show that you're on. And, I'm not quite the establishment guy. So these people they have dissenting opinions. And you just wonder what their daily life is like, what kind of room they have to actually get things done. I have no idea. I mean, it kind of reminds me of probably what Tulsi Gabbard goes through at the director of National Intelligence Office that she heads, where I don't know exactly, are they, I hate to speak flippantly about such serious matters, but if it's one of those things where they get pretty direct threats or indirect threats, or they say, hey, Bob, I want you to research what Paul Marik's doing. And then Bob says, yes, sir. And then it never happens. And then he says it again, like Groundhog's Day. Hey, Bob, Deep State Bob, that I know you work for Pharma, but could you please research what Paul Marik's doing today and give me a report? I'm sorry, sir. I'm busy. I'm going to be away on vacation or something. I mean, what? I don't know exactly how this actually sausage making happens. I'm curious to see.
Yeah, it is interesting because I mean, I think, although people criticize Kennedy, he's a very smart man
Yeah.
and he has an enormous knowledge base and a lot of information. He's
Mhm.
in a really difficult position
Yeah.
because of all the pressure that these stupid other senators put on him and
Yeah.
Congress puts on him because these are ignoramuses
Yeah.
that don't understand the medicine that are pressurizing him. So he has to walk a very fine line between changing things and not upsetting too many people. I mean, you talk about vaccination. You hear Bernie Sanders talking about vaccination. I mean, what the heck? He's not medically qualified. He doesn't understand the complicated science, and now he's arguing. It's an absurdity.
Yeah. Well, I mean, that's the nature of the beast. I think we're going to look up, but it's not going to change. The internet, again, for all of its flaws, has broken a dam of censorship and groupthink, and the level of prestige that boomers have placed on the white hat mafia. I mean, excuse me, the white coat mafia, and and I'm not taking away from doctors, but this whole groupthink of the doctor said it, I believe it, that settles it. That kind of religiosity towards the medical establishment is coming quickly to an end, rapidly to an end on the younger generation side. You can't see it right now because boomers make up so much of the economy still that it's created this kind of false sense of normalcy and insulation from rapid change. And of course, boomers make up the voting bloc majorities as well, especially for the primary picks, which is where you have your chance to actually pick somebody who would go against pharma. Um, but you only get a couple people who are able to push against the status quo, and their days in Congress are very, very challenged because they have so much, money just flowing in against them. But I think we're going to wake up and realize quickly when it comes to younger generations, they're not going to continue to fund this. We're going to look at this time like, my God, we went through that long. I mean, that kind of criminal malfeasance as medicine had that level of control over not just this country's bodies, but the whole world, because the whole world is kind of under the thumb, as Fauci demonstrated, our medical establishment.
No, I agree with you. I think there's growing dissent with the system, and more people are losing faith and trust in the system. So I think, and questioning. So I think I agree with you. That's a good thing. So hopefully this will lead to change.
I appreciate your time, sir. Can you tell us where we can get your book or anything else that we should look out for in your
Yeah,
closing thoughts?
yeah. So my book's available at Amazon.com called Cancer Care. The other thing is I work for the IMA, Independent Medical Alliance, and we have a website, the imahealth.org. Just look up IMA. And on the website, we have a cancer hub that has my book for free if you want to download it, as well as some other resources. So, I think people have to empower themselves. They have to read, they have to educate themselves. And so, you don't believe what I say or you say, you want to independently read and make your own judgment. So, my book's available on Amazon.com, or you can go to the IMA website. I think it's imahealth.org, and you can download this information.
I appreciate your time, sir. Thanks, Dr. Paul Marik. Really appreciate your work and your courage.
Thank you, David. Thanks. It was a pleasure.
Thank you.
Joy.